Hey MedAxiom Heart Talk listeners, a quick heads up. We recorded this episode in April during the early days of the COVID-19 pandemic. While we did briefly touch on how the pandemic has affected access, the focus of the episode you're about to hear is on the general governance and culture issues that impact access. And speaking of those two topics, MedAxiom is releasing a white paper later this week called It's Time to Think Differently About Access. The paper covers the importance of culture and governance in achieving wide open door access success. You'll find this complimentary paper at medaxiom.com/publications. That's medaxiom.com/publications.
Patients aren't very satisfied when you tell them to come back in a year and you don't have the ability to see them in a year. And so we've been able to shift a lot of those people who were scheduled to come back and see a physician for a routine follow-up to see the APP.
Welcome to MedAxiom Heart Talk, the podcast where thought leaders come together for one ultimate goal: to continually transform and optimize cardiovascular care for all. MedAxiom Heart Talk starts now.
This is Cheryl Toth, host of MedAxiom Heart Talk. Year after year, access is one of the top concerns we hear from cardiovascular programs and practices. How do you get new patients in the door if you have no place to put them on the schedule? Our guests today are going to dive into the issue of access and explain why governance and leadership are so essential to operational and clinical success. They'll share insights and learnings from organizations that either are working on or have solved the access problem. Joining us from Kansas City, Missouri, is cardiologist Dr. Joseph Goeke, who practices at St. Luke's Cardiovascular Consultants. His group of more than 60 cardiologists and nearly 50 advanced practice providers has developed a model for getting patients on the schedule within 48 hours and often 24. And from Grand Rapids, Michigan, we have MedAxiom's Senior VP Consulting, Ginger Biesbrock. As a consultant, PA, and administrator, Ginger has worked with hundreds of physicians and administrators to create effective access solutions. Ginger, Dr. Goeke, thank you both for being here today.
Thank you.
Thank you for having me.
Ginger, you've worked with so many programs over the years. You've seen the good, the bad, and the ugly. From your perspective, what are the most important things to have in place in order to get at and solve the access problem?
Well, I think there's probably two foundational elements. One is just admitting that you have a problem. So still so many times we go into programs that the leadership and the physician leaders, both the administrative and the physician leaders, are not necessarily in agreement that there really is an access issue. And we have to turn to data and really kind of show that there is. I don't know that I've been in a program recently that hasn't had some level of challenge around access. And so I think it's a matter of defining what you want your goal to be, which is basic. In many cases, our patients are defining that, or our markets are defining that. And then understanding really where you're at. So I think number one, admitting that might be a challenge and measuring it. And then number two, having a governance venue in which decisions can be made related to redesigning your care delivery model. Most of the time, access cannot be solved by simply working harder or adding more slots to already filled schedules. You really have to rethink how you deliver the care. And so I think those two pieces to start with, without them, typically you will fall short.
So you're really talking about setting up this idea of a governance and a culture that supports what's next. And Dr. Goeke, tell us a little bit about your governance and culture when it comes to access. How would you describe it from the standpoint of how you've been able to solve the access problem?
Well, we have a true equal share practice, and it's been that way all the way from our days as a private practice now through an integrated multi-specialty group, where we're a very subspecialized group, but we treat every area of the practice as equal. So we have very shift work mentality rotations. And so on a day when you're in the office, we're not doing a multitasking of some in the hospital, some in the office, some echo, some that. So when you're in the office, it's a dedicated day. And the way that we've done it across the practice is a day in the office is the same for everyone. It doesn't matter whether you're here for a day or whether you've been here for 30 or 40 years. Everybody has the same number of patients on their schedule. Everybody has the same amount of time to see new patients, establish patients. And so with that, it allows us to look at it from, like we do with all of our rotations, from what's best for the practice and make big changes. So some years ago, we looked at, from an economic model, where does, the revenue come into the practice? And we all know that a new patient generates testing, and they're the ones that need the most intellectual time to figure out what's going on and coming up with a plan. And so we took that as a practice goal of prioritizing new patient access. And we simply said, all right, we started off, on a given day, our typical day is a 20 patient day. And when we first started this, we said, all right, we're going to block 20% of our slots for new patients, and we won't open those slots up until 48 hours before the day of the office. And as we hit on that 20% level, then we increased it to 25%, and now we're sitting at about 23%. So we were able to do that across the board because we're a very equal practice, and so with everybody having the same schedule, we're able to make that change for what we think is best for the practice and put it in place that way. So that was how we did it. Now there's downstream consequences of that, because then it becomes harder if you're blocking a certain percentage of your slots for new patients and sick patients. Then you have to figure out how to see the existing patients. And so we've made multiple changes to try to combat that with more APPs and collaborating with primary care doctors in more formal ways and that type of thing.
Well, now, and so this equality issue and with the 20% of new patients, they raised it to 25, now you're around 23%, and there's this consistency. Why do you think that's been so successful for you? I mean, how did you get to that success when so many other practices struggle with that?
Well, I guess part of it is being a bit of a socialist mindset, where when the practice decides we're a physician-run practice, and so when the decisions are made, it's made by me and my coworkers, and so it's a little bit easier for people to buy in when it's not pushed from above from administration. It's pushed from physicians looking at our problems and seeing that we need to be able to get new patients in. At the end of the day, it's also more exciting to see new patients. So most of us, after you start seeing some new patients, you realize that, these use more of my brain power. They use more of what I've been trained to do. And so people were much more willing to do it after we kind of put it in place.
Well, and so this mindset of being able to see more interesting patients, if you will, and getting the physicians to see that they're making the decisions around this is great. That's from the physician perspective. Ginger, I'm going to switch it over to you in terms of mindset. What do you think care teams need to have if they want to truly offer open access? What have you seen work in this way?
From a care team perspective, one of, I think, the important pieces is that the team comes together. So in this case, physician, APP, probably scheduler, nurse, kind of that functional team unit, and but really understanding and prioritizing what each member brings to the table. So Dr. Goeke described those new patients, and those new patients requiring significant clinical decision-making, which requires his training as a cardiologist. And so when we have a physician schedule that's filled with follow-up patients, with you're just facilitating a care plan that's already been in place, that's a great role for a shared care model utilizing the APP. Mm-hmm. And so as those teams begin to come together and form around that particular patient population or patient panel, having those discussions around which patients make sense based on the different, the physician, the APP, the skill set to meet the objective needs. And what you'll find is kind of what has evolved with Dr. Goeke's group, where you really prioritize those new patients and the ability to scale up to meet the new patient need by developing a shared care model where the APPs can follow through on really facilitating that plan of care that's been put in place.
And Dr. Goeke, how would you describe the structure of your governance and how you got to that point, how you integrated those APPs and how you built out the care teams?
Well, the integration and expansion of our APP workforce is something that certainly had its ups and its downs. We actually had Ginger come in and consult with us a couple of years ago to help through the process. We went from, over the last 15 years, as I've been with the practice, we went from having less than a dozen APPs to 50 and close to 60 APPs now. And that created its own set of problems. We at 1 year added, I think it was 18 APPs in 1 year, and that's very hard to integrate in and figure out how to use them successfully. There's a lot of retraining from the physician side on, what is the role of the APP? Are we comfortable with these APPs? We were hiring brand new grads. And so it really has been an evolution, and it took a really strong APP leader from within their ranks to be able to, calm the masses down, to come through with a very consistent message. This is how we're going to do it. This is why we're going to do it. Make sure that the training was in place for the APPs. We started an APP fellowship program within our institution to help all these new grads get a more broad-ranging base in cardiology and in all their, whether they're cardiology or critical care or hospitalist. And so that has really been a key part in making this work. The care team model is really important, as Ginger emphasizes. We have grouped physicians and APPs and nurses into very small individual groups, even though we have 120 providers. My little team is me and an APP. Now the APP may work with a couple of my partners as well, but I know that I have an APP who's going to be seeing my patients. And so that's a lot easier to sell. It's a lot easier to get comfortable with that. It's a lot easier for my APP to know the way I practice and what I am looking for and anticipating. So it was a long work in progress and process, but it's in a very nice balance right now.
Well, and it's taken you a number of years to get there. And you mentioned, Dr. Goeke, some of the success factors, like having a strong APP leader, explaining how and why. And Ginger, I'd be curious, as you work with programs around the country, what are those factors that those listeners out there saying, we want to move to this, we need to modify our governance and leadership to create this culture of access. What do they need to do to achieve success?
Yeah, I think, again, there's probably a couple things here as well. One is developing a shared vision or a shared priority that this is going to be a priority of the program. I also think a combination, we talk a lot at MedAxiom about the dyad leadership, so strong physician leadership, which Dr. Goeke's program has also emphasized, that working closely with administration in very much of a partnership sort of way. And so kind of, the physician leader brings the vision. They develop the vision together, but brings the clinical strategy, brings the leadership over the provider group, and the administrator helps to operationalize that. So understanding the budgetary needs, the staffing needs, running the numbers, monitoring the outcomes from an operational perspective, and really supporting the model that way. And so we find when the two are able to come together, this can work really well. And so that dyad, and in Dr. Goeke's case, he talked about the strong APP leader. To me, that would be a great model of a triad model. And so we have, you've added that APP leader to that team to really kind of review and be part of the optimization, if you will. The third piece of that is having a venue in which these decisions can be made. So whether that's a practice clinical committee, a clinical operations committee, an ambulatory committee, but some committee where the physician leaders, the administrative team can come together again to make decisions on how to scale, how to adjust schedules, what do the office operations or clinic operations look like, and have the ability to make decisions that need to then can be scaled throughout the entire organization.
You've both talked a lot about the different success factors that have been in play at your organization, Dr. Goeke, at St. Luke's, and also others, Ginger. What kinds of things would you advise programs measure? Let's start with Dr. Goeke. What are you tracking on a monthly basis?
So we really keep it pretty simple. New patient percentage is something that we're tracking very closely. We track the number of patients seen per hour. We have a schedule that is 20 patients for the physician in a 9-hour day. So we do 25-minute slots, and we have, our budget is that we hit 18 patients out of 20 in a day. And so we look at that, and on a monthly basis, that is distributed to the group unblinded. So you see what the group's total is, and you see what individuals in that report. Also shows the number of hours in the clinic, so you can get some idea of scale compared to other people in the group. We track no-show rates, which has historically, thankfully, been very low up until this COVID-19 crisis. So those are really the main things.
And Ginger, any metrics you'd add to that? And I'd also wonder if you might take one or two of those metrics and talk about how you've used them with programs in terms of measuring success over time as maybe they're implementing some of these things.
Yeah, absolutely. I think one of the other common metrics that we see is monitoring third next available. So third next available new patient slot and third next available follow-up patient slot for each provider and physician, just so you can kind of see where the schedules begin to open up. And there's always a story behind that, so you have to understand how your scheduling works and how the system is set up. But that's a pretty common one in the industry. Some programs have developed a see within 5 days or see within 48 hours or 2 days for new patients, or at least have the ability to offer an appointment, whether the patient decides to take it or not. And so some are able to track that through their practice management system and see how close to goal they're able to get in their ability to offer that. That's a really important one, because, and as well as the third next available for that new patient, because as you monitor that and if you follow that on a weekly basis, that can give that administrator and physician, the leadership team insights on, do we need to scale up? So Dr. Goeke gave the example. We started at 20% new patient slots. I'm assuming that wasn't enough, so they still were farther out than they wanted to be, so that moved them to add another slot or two on each physician's schedule when they were in clinic to get it up to 25%, and then they were able to scale back a little bit. And so understanding those metrics allow you to do that. Another couple areas I would also urge folks to look at is their patient satisfaction scores. The typical CGCAP patient survey has several questions around access, and really looking at it from the patient's perception. And patient perceptions, again, are really important. We, sometimes as a provider team, in our minds, we know how urgent a particular symptom or need might be, and we may think that's a very elective, not an urgent sort of thing. But oftentimes our patients feel differently. And so it's understanding kind of their perception of our ability to meet their needs, I think is really important. So monitoring that and getting that information back in the hands of the physicians and provider teams is really important. And then the other one that, again, I think I've been doing a lot of work around physician and clinician burnout. And so I really think an annual touch base to understand where everybody is at on the provider team from an engagement perspective. Do they have what they need to do their jobs? That can go a long way in understanding what that team needs to be as efficient as possible, but also to maintain the patient relationships and that sort of thing that they need. And
so following that, go ahead, Dr. Goeke, anything to add?
Yes, another thing that I should have included, that we have, as a consequence of prioritizing the new patients and the sick patients, while we're very good at getting them in, that has left a gap, since we're in a great situation where we have more patients that want to see us than we have time to see them. we have traditionally had what we call as our wait list of patients that we've said to come back and see us for routine follow-up, and we don't have immediate availability to see them when we said come back in a year, and in a year we don't have a slot for them. So that number has historically over the last number of years been a significant number for us. And as part of the patient satisfaction that Ginger talks about, patients aren't very satisfied when you tell them to come back in a year and you don't have the ability to see them in a year. And so that is something that we've really focused on this year with the goal of reducing that wait list. We had set the goal at the beginning of the year of reducing that by 25% by the end of this year and by 50% by the end of next year. We're much further ahead of target on that than we had set the goal for, which is great. And that really led us into some of these other things that we're doing to try to leverage the physicians with APPs. We've actually took the initiative of sending a letter out to all of our patients explaining the transition to the inclusion of APPs into the care team models, explaining, a letter came out from me, for instance, to my patients saying, my APP, giving her name and explaining her background, is working as part of my team, and you may be asked to follow up with this provider. And then we took it a step further, which was another one of those things we didn't know how well it would be received, but actually proactively calling patients who, for instance, were scheduled to come in for an annual visit with me and saying, Dr. Goeke has looked at your chart and you're doing very well. And I don't remember the exact wording, but something along the lines of, we can get you in to see his nurse practitioner who you got the letter about immediately, and she will confer with Dr. Goeke. And then that worked very well, actually. We've been able to shift a lot of those people who were scheduled to come back and see a physician for routine follow-up to see the APP. And that has really has filled the APP schedules with very appropriate patients and has offloaded that wait list. And so we're way ahead of our schedule for reducing that wait list. And hopefully we anticipate being down to, essentially zero by at least the end of next year, and hopefully far way into that this year.
So we've got this combination to create that cultural underpinning and governance, this shared vision, a venue to discuss things, scorecard metrics, tracking those for success, proactive communication, a lot of good things in this conversation. And we're going to continue this conversation after we take a short break. So don't go away. We'll be right back with Dr. Joseph Goeke and Ginger Biesbrock. Access is a complex problem. Many organizations work to improve it incrementally by modifying scheduling templates and protocols and recruiting APPs. And while these changes can certainly help, they won't solve the real problem. To truly solve your access problem, culture matters. MedAxiom's new white paper, It's Time to Think Differently About Access, Success Requires More Than Operational Change, is set to be released later this week. It outlines 5 factors that must be in place to create a culture of access and truly achieve wide open door success. Developed by consultants Ginger Biesbrock and Joel Sauer, the paper includes practical guidance and a self-assessment designed to help CV leaders identify gaps and opportunities. Download the white paper at medaxiom.com/publications. That's medaxiom.com/publications. We're back and we're talking with Dr. Joseph Goeke and Ginger Biesbrock. Now, we're recording this in the early weeks of the COVID-19 crisis. So, Dr. Goeke, what impact has your leadership structure and your culture around access had on your ability to respond and get patients in a timely manner? What are you seeing so far?
Well, obviously, this is an unprecedented problem, and as we've seen from the webinars that MedAxiom and AACC have put on, trying to figure out how to see these patients, which patients need to be seen, how do we do it safely, both for us and for the patients, is something that's been an evolution. We set up a number of task force from the very beginning to focus on different areas of this. One was a virtual visit task force that pretty much immediately we shifted to a 0 patients in the office being seen in the office scenario. We've had very, very few physical patients in the office, and we went completely to telephone only, and then have integrated in the video visits as the capacity, as the technology has been, as we've caught up with the technology. So that's given us the flexibility. And so we have APPs doing the virtual visits, we have physicians doing the virtual visits. We're able to combine clinics, our outreach clinics. We're not traveling to the outreach because we're doing that virtually. So we're able to scale up the number of patients seen in those sites. So in some ways, it has improved our ability to see patients. And it's been very interesting as we've done it, especially in the beginning when all we had was a telephone. For these patients who I know, a telephone visit, you can feel very comfortable that you know what's going on with the patient, and if they're stable, they're stable, and you can make minor adjustments. And the video actually adds a little bit, but it isn't necessary even for a lot of these patients. So I think it'll be very interesting how we change as a result of this.
Mm-hmm. Those are some great lessons you're learning then. And how are patients taking the change? What kind of feedback are you getting from them in these early days?
Well, patients are understandably as worried as all of us are about getting infected. And so many of them were quite relieved to realize they weren't going to have to come into the office. For many of these people, coming into the office is a bit of a chore, right? They have to have family members or, someone from the nursing home, or just the logistics of getting into the office and the time it takes them to get here, and the waiting room and the check-in process. It's certainly a lot more patient-friendly for them to be able to sit in their family room and either talk to us on the phone or link in from the video. So the reception has really been phenomenal.
Great. And Ginger, what are you hearing, seeing, learning from members from this crisis?
Yeah, so I think it's been amazing, first of all, to watch our partners and community to really pivot quickly. And fortunately, we've had some legislation that's allowed us not only we did the right thing first, and now there's some reimbursement for that to help with the business side of things. But that being said, it's been amazing how quickly programs have been able to come together. Now, some were able to do it a little faster than others. And it's, again, to kind of reiterate some of the things that Dr. Goeke described, developing those task forces. Well, those task forces came out of their current governance and leadership structure, their ability to allow a small number of people to focus on a problem, develop a plan, and then implement the plan, and everybody was going to follow along with the plan. So allowing the leadership team to appoint folks that make decisions that are best for the organization, and then moving forward on that quickly, again, I think is very important. Other challenges that we've seen, and those are just things that we're going to have to see, that sometimes compensation models kind of get in the way of our ability to pivot quickly on things. And so in cases where they're much more individually incentivized, making some of these transitions and utilizing different team members has been a little bit more challenging in best understanding how to do that. So I think it's again, at the end of the day, the entire industry has done an amazing job to figure out how to best care for patients. The feedback we're getting is that patients, again, to Dr. Goke's point, are incredibly appreciative because they didn't want to come in either. And so we've really been able to meet that need and do it quickly. But I think that, again, that governance and leadership structure, having it in place, allows for when these things kind of come down the pike that are unexpected, allows us to, or allow those programs to pivot a little bit quicker when they have a place they can go for these decisions to be made.
So for those programs and practices out there who've maybe realized during the COVID-19 crisis, or just listening to some of these examples that we've been discussing today, they realize they've got to make some improvements. If they truly want to get at solving their access problem, they've got to change that governance structure and some of the leadership. That I know can seem very overwhelming, especially when they're busy. It's like, get have your finger in the dike, but then you're trying to make all these bigger changes. What are some of the small steps that listeners can take to start moving the ball forward?
Well, I do think it's hard. It's hard to change culture. And so in a period of rapid change, that's a hard thing to do. Although in a period of rapid change, sometimes some of the long-held beliefs, people are have a little easier time giving those up when they see that we have to make some big changes and it's not worth fighting over all these little things. So that may be never let a crisis go to waste. This may be an opportunity for to be able to deal with some of the issues that perhaps have had some pockets of resistance over time. Problems that we've seen with other groups, as we've discussed at MedAxiom meetings and small group meetings, if you've got a compensation structure where the APP is in competition with the physician, that just is a recipe for disaster. And so those groups are having a hard time right now, I would imagine. And so hopefully it puts the spotlight on some of those and allows groups to identify some less than perfect situations, and maybe once things calm down, that gives them a little momentum to make some of those changes that will be the building blocks for making more substantive change to a true care team model, which seems to be what most people are getting on board with, at least in theory.
Mm-hmm. Ginger, what are some of the steps you'd suggest?
Yeah, I think getting your hands on that real-time data. I'm often amazed how much our perceptions are oftentimes different than the reality. We all typically, and I'll say for myself, I typically think I'm a little better than maybe what I am when I look at the data or what my actual outcome was. So oftentimes when we ask the questions around, are your patients getting in? Do you have long wait lists? Do you, if they don't know, they're assuming that it's not too bad. And then when we work with programs and actually pull their data and look at, for each and every physician and each and every provider, where you're at and how many days you're behind and seeing these patients that are sitting on wait lists or your next new patient availability. We've even done some kind of cold calling to find out when we can get seen and find out that it's 10 weeks from now. So that is very motivating, because it's the reality is we all want to meet the needs of our community. And so I think if you haven't done that piece of it to really understand where you're at, that oftentimes can start to get the ball rolling. And then again, to Dr. Goeke's point and what's going on, these times make us start to think differently, they force us to act differently, which gets us to start to think a little bit differently. And so I think there's going to be a lot of really key learnings that come out of all of this that will help us in the future.
Great. Thank you so much, Dr. Goeke and Ginger. Really appreciate you being our guest today on MedAxiom Heart Talk. Thank you.
Thank you.
Thank you for having me.
And thanks, everyone, for joining us today on your commute, your run, at your desk, or wherever you listen to MedAxiom Heart Talk. To get MedAxiom Heart Talk delivered automatically, become a subscriber on Apple, Google, or wherever you get your podcasts. And if you like what you learn here, please give us a review on your podcast app. If you prefer to give us feedback directly, send an email to hearttalk@medaxiom.com.